thank you for the kind introduction. And thank you for the opportunity to speak here today, actually. So now as we are approaching the end of this amazing day with fantastic talks, I would like to sort of take a step back and look at something that is actually quite crucial. It's a crucial momentum in all sort of advanced image analysis, and that is tumor segmentation. And I'm pretty sure that many of us, if not all of us, have worked with this or are working with this in our projects. So here's the outline of my presentation. So first we're going to talk about segmentation in general, and then after that we're going to talk about the longitudinal analysis pipeline, which is a work in progress by Serker. But before we do that, let's have a look at segmentation. So what is segmentation? Well, this is actually the process where we are trying to visually divide pathologies into different parts, because as I'm sure most of you are aware, brain tumors manifest with different parts histologically, histopathologically, and you can get these areas where the tumor is sort of infiltrating the normal tissue. That is usually what we see on T2 weighted FLAIR images as a hyperintense region, along with the peritumoral edema, of course. Then we can get a blood-brain barrier disruption, and that manifests as T1 hyperintense enhancing tissue on T1 weighted images after contrast, of course. And then we get these necrotic cavities with dead tissue, basically. So what we would like to achieve is to sort of differentiate, to sort of delineate these different parts by segmentation. And then we get something like this as a result. It's important to also realize that the reason we need segmentation is in order to achieve something, maybe a paradigm shift on the long term, because as many of you know, nowadays we need, of course, a tissue sample to make any sort of pathological diagnosis for brain tumors. And there has been this paradigm shift where we are trying to have a vision on doing this just based on imaging non-invasively by sort of taking a virtual biopsy. And we heard this morning as well that we have to get better and that we could make it better. But, and obviously this is not something that we are even close to. So this is just sort of just a vision. But hopefully segmentation along with other techniques, if done correctly, will help us on the way towards this paradigm shift. And currently, segmentation is a very important baseline or basis for all these things that we do in research and in clinical practice. So obviously, currently in research, we can look at the imaging appearance of the brain tumors. We would like to find the information that we currently actually can only find with histopathology, molecular, and genetic analysis. We would like to find this information in the image. And that's how we can utilize a good segmentation in research currently. And we can perform texture analysis, extract quantitative features of these tumors. And one good thing with segmentation, as opposed to, for example, a tissue biopsy, is that we can consider the entire tumor as opposed to just a small bit of tissue. And obviously, it's a non-invasive thing to do. In clinical practice, we are moving towards precision medicine, and a good segmentation can obviously facilitate this. But what is more important is actually the surveillance and the prognosis assessment. And yeah, so these are the most important components here. So we need to realize that proper segmentation sets the ground and is necessary to set the ground for AI-based tools in non-invasive brain tumor assessment. And there are a couple of different ways to do this. Manual segmentation obviously is tedious, time-consuming, and confers a high inter-rater variability. We can do semi-automatic segmentations, which are a combination of automatic and manual segmentations, usually requiring some sort of manual correction by the user. And obviously, our goal is to develop high, automatic pipelines with high accuracy for this task. Let's have a look at the semi-automatic segmentation. This is something that we also use in our research projects that we do together with Serker. And let me just tell you a couple of steps here, like how it is done. So basically, we take images with different weightings, pre- and post-contrast images, and we will try to create something like that. So the first step is to classify the tissues. So the user will have to delineate some samples, some tissue classes, which then the model will use to predict the different tissue classes that are in the entire pathology. So we label these structures, the contrast-enhancing tissue, the non-enhancing tissue, and the necrotic cavity. And after that, the model creates a sort of a pre-segmentation, a prediction, and then we just put seeds into this area and sort of make it grow, make it delineate that specific tissue class. And after that, if the user thinks it's necessary, we will have to do manual correction. Some pitfalls that arise during this process are blood products, for example. So blood products can have, as many of you probably know, T2 hypointense appearance or T1 hyperintense appearance, depending on the age of the blood product, and that can be a confounder. So, for example, if we want to label the enhancing tissue that can have the same appearance as just blood, and that also has to do with the fact that multiple tissue classes can be present in the same voxel. So then it will be really difficult to assign one certain tissue class or label a voxel as a certain tissue class, because you will have both components. It can be blood, it can be necrotic component and contrast-enhancing tissue next to each other as well. Then we can have adjacent structures which are sort of merging with the pathology and have the same signal intensity. And again, in order to remove these tissues, you usually need manual correction. And finally, we can have all these pathologies that are not tumors, that are some different pathology or depend on aging, for example, and that have the similar appearance, the similar signal intensity as your tissue class. For example, white matter hyperintensities are like that. Let's have a look at some automatic segmentation features. So here are some important desired features for an automatic pipeline. Obviously, we want it to be reliable and reproducible. We would like it to be fully automatic and accurate so that the user doesn't have to interact at all. The desired dice similarity coefficient above 0.8, but as high as possible, obviously. And it has to be fast and accurate. We also have to consider that people usually lack time for these sort of things. So we really need to use these tools in order to spare time for ourselves. And here is actually a project that we conduct together with Serker. So this is an external validation project of an automatic segmentation algorithm. And as a reference, we use semi-automatic segmentations by two readers. for this external validation study, and we would like to validate this algorithm both at a voxel and at a region of interest level. And here you can see the specifications of the model. And finally, let's talk a little bit about longitudinal analysis. So we have heard this in the previous presentations, that actually the overall survival of the patient can be, certain MRI features, the volume of the contrast-enhancing lesion and even the non-enhancing lesion is associated with the overall survival of the patient and the progression-free survival of the patient. So that is why it's key for us to sort of get a longitudinal picture that is also that is accurate and reliable. And obviously, another reason why we would like to follow these patients and get a good quality of these longitudinal analysis is that we would like to catch a conversion to a higher tumor grade. This has been mentioned before, the Raynaud criteria. So when we do surveillance in research for clinical trials, but some centers, even in clinical practice, they use these criteria as an objective measure of tumor progression or stable disease or tumor response. The most important components of these criteria are listed here in this table. So we have the contrast-enhancing tumor size that is quantified, the non-enhancing tumor size, which has qualitative criteria, so increase, decrease, or stable. And then obviously we are interested in seeing new lesions. Two key questions, as we already heard here before, are pseudoprogression and pseudo-response. So these are phenomena which we can see after irradiation or after chemotherapy, which are not true progressions or responses, obviously. And here we can see some examples for this longitudinal analysis pipeline, which is an amazing work conducted by colleagues at CERCare. So this will look, the report will look something like this. We will get some indications of decreasing or increasing volumes of enhancing tissue, non-enhancing tissue, and so on. And for example, in this case, I think this is quite useful for the radiologist because you have multiple foci of contrast-enhancing tumor, and it can be quite difficult to see over time how the total volume of these enhancing lesions have evolved. So when you get these curves, as you can see it here in the lower part of this report, it actually helps you give a quick overview of what has happened during this follow-up time. And another ambition that we are, or CERCare colleagues are trying to work on is to incorporate perfusion maps into this longitudinal analysis pipeline. So hopefully it will be possible to assign regions of interest, maybe initially manually, but hopefully even automatically at later stages. And so you can then get a longitudinal sort of overview over the quantitative features of the tumor as well. Here's just another example. So it's also, very useful when you're looking at postoperative images because you can get those contrast-enhancing lesions at the resection cavity rim. And so it helps you sort of get a more comprehensive picture of the pathology. And so here are my references, and thank you for your attention.
Questions? So I was wondering whether you look let's say you've heard the two previous talks about this, the multimodality, if you will, of how tumors are being diagnosed and followed post-treatment and so forth. An initiative like you demonstrate here, how difficult will it be, you think, to incorporate many more modalities than you have shown here?
Well, I think the biggest challenge probably is to incorporate any sort of quantitative analysis. But
right.
Once that is done, I think there are less limitations to incorporate further, maps,
right.
if you want, or parameters. That is my hope, and I really hope that this will happen in the near future.
Right.
So.
I heard that at some hospitals, the practice is that some of the follow-up scans are conducted elsewhere.
Mm.
Is that a problem for the kind of quantification and standardization if that's done, let's say, in private clinics?
For sure,
yeah.
For sure, because you might get, images of lower resolution, lower, quality, lower signal-to-noise ratio. However, for high-resolution images, I think that will be less of a problem because you will still be, if your segmentation algorithm is good, that will probably be able to sort of make this accurate regardless.
Yeah, so that could be robust.
Yeah, but with low-resolution images, I think that will be a problem.
Right.